and your mic. We can see you, and then I'll hand over to you as I just bring up your presentation. So if you just bear with me as I make that transition.
Perfect. Thank you, Nick. It's a great pleasure to be talking about the virtual wards and heart failure at home that we have been doing for a little while at Barnet Hospital and for a little less long at the Royal Free, but then working with Haringey and using their experience with the Heart Failure at Home project that they've been involved with. So it's been a great time for North Central London and our experience with the virtual ward using Ortus as the platform. So that's my first slide. I'm just going to go through the problems we face, and it comes as no surprise to anybody, I'm sure, on this call, the burden of heart failure that we face with 1 million inpatient bed days, 2% of all NHS inpatient bed days. Acute heart failure is the leading cause of hospital admissions in patients over the age of 65. And heart failure is estimated to cost around 2% of the NHS budget, 130 billion. 70% of all heart failure costs to the NHS are due to hospitalisation. And this is only going to get worse as time goes on and we diagnose more patients with heart failure, and hospital admissions are projected to rise by 50% over the next 25 years, which is fairly frightening statistic and something that we have to bear in mind when we're trying to organise our services. Next slide, please. And I'm sure everyone is also familiar with the readmission and this circle and cycle of stability and hospitalisation and continued disease progression, and what we think constitutes a stable heart failure patient. I'm not sure they ever are truly stable. And so they go from being the inpatient, stabilising them on the wards, getting them well enough to be discharged home, but usually not completely euvolemic and not completely well and mobilising around the wards. Discharged, and then we know that post-discharge period is really a vital time when they may be readmitted to hospital, which is really awful for the staff, but absolutely awful for the patient having to be re-hospitalised and back onto the ward. We know that the patients admitted with heart failure carry a high mortality rate, and inpatient mortality across the country is around 10%, and that 30-day mortality is 16%. Next slide, please. One before. And they remain vulnerable, not just for weeks after their admission, but also for months. And that phase has been described up to 6 months, where they can be readmitted and really not stable at all. So whatever we can do to try and stabilise the patient in a better way than we have achieved up until now can only be a good thing in my mind. Next. So again, you will be familiar with the 4 pillars of heart failure medication: RNA, beta blocker, MRA, and the SGLT2 inhibitor. And I would also say that there's a 5th pillar, and that being that of heart failure rehabilitation, and something that across the country we're not brilliant at. We don't always have the services set up. But the virtual ward, by virtue of the patient being at home, is now then not stuck in a bed on a hospital ward, but is able to mobilise around their home in a much more natural environment than being stuck in the ward and usually stuck in the bed at the same time. So I think that's a really important 5th pillar, and really lends itself well to what we're trying to achieve with the virtual ward. Next slide, please. So from the National Heart Failure Audit, we're aware that really patients who are admitted with heart failure need to be looked after by a cardiologist or a heart failure specialist. And if that isn't the case, then they don't get started on the right drugs and they don't get given the drugs at the right doses. And we see this time and time again. And I guess it's a little bit depressing that in 2024, we're still having to say that that's the case. It should be really obvious that patients with heart failure are looked after by heart failure specialists. But we know that isn't always the case, and patients therefore are denied prognostic drugs to help them recover from heart failure and to keep them out of hospital. And so we must always bear in mind that patients with HFrEF and now increasingly HFpEF need to be seen by a specialist. Next slide. This is just to remind us that if patients make it to a cardiology ward, they're much more likely to have cardiology follow-up, heart failure specialist nurse follow-up, and that impacts on their prognosis and impacts on their likelihood of being readmitted or kept out of hospital. So what can we do to influence this? Well, as you are all, I'm sure, aware, traditionally, what we have done is started one drug and got them increased, the dose increased in that, and then added in another drug, and maybe we might add two drugs at the same time, but then at really low doses, and start low and go slow was the mantra for a very long time. And this whole shenanigans could take up to 6 months of increasing the dose, checking the kidney function, getting the patient back to increase their drugs, checking their blood pressure, etc., etc. And then, of course, blow me, what happens is the patient's readmitted with a fall and the whole lot is stopped, and then you start from scratch again, if you even know that the patient's been readmitted. More often, you can be seeing the patient in your heart failure clinic thinking that everything's all tickety-boo, and in fact, they've had their heart failure drug stopped. So this is not a great way for the patient to be managed. Next slide, please. So STRONG-HF gave us a real pointer into what we can achieve in a very short space of time safely, using NT-proBNP to help guide whether the titration was effective or whether you needed to hold fire on up-titrating the doses and keeping at that dose. But essentially, within 2 weeks, patients were safely up-titrated on appropriate doses for that patient, best optimal dose of the 4 pillars of heart failure medication. And the high intensity care patients had a reduction in the readmission rates for heart failure and indeed all-cause death. So really important, really a seminal trial in guiding us that we can do better, and we can up-titrate patients much more quickly than we have done traditionally. Next slide, please. So moving on to Ortus, this is what we can do. So this is the app, the platform where patients can add their data to the platform, and then it can be viewed virtually. So Donna's going to talk about that in a bit more detail, but essentially we can find patients, next slide please, who are suitable. We can go to our homepage and configure it how we would wish to find the patients that we have recently been looking at. We can personalize it, and we can then access information for audit trails, etc. Next slide, please. And we can have several patients on our virtual ward where they input the data. We can see what's happening. We can look at their blood pressure. We can look at their weight. We can see if they have any new symptoms or worsening symptoms, and virtually manage them on the virtual ward. Next slide, please. This can be managed with traffic lights, so we can see this can be individualized to the patient for their vital signs, so that we can see whether they are within the parameters that we're hoping for in terms of their blood pressure or heart rate, or if it's a bit high or if it's a bit low, or if they have any new symptoms that they're concerned about. And then we can contact the patient if necessary, or we can continue with the up-titration if everything is within the normal limits. Next slide, please. So here we can see that there are, we can see on the questionnaire, so that allows us to audit and track things, what's happening with the patient and how they find the Ortus platform. We've had excellent feedback, easy to use, and we can also look at their symptoms, heart rate, blood pressure, weight. We can look at the oxygen sats if necessary. So on our virtual ward, we can then look at all of this and then decide whether the patient needs to be contacted at all that day, or whether they can just continue on the virtual ward, or whether we will need to contact them just to see how they're doing. Next slide, please. So the objectives are to reduce length of stay. So we're trying to get patients home earlier when they've been admitted with decompensated heart failure. We're also trying to use the Ortus platform for admission avoidance, to provide more joined up care between the inpatient team, the outpatient team, the community team and primary care, making better use of the community services, and of course making it a better experience for the patients and improving their outcomes. Getting them home is always a good thing. Next slide. So the patients are identified on the wards or in clinics, sometimes in the assessment unit. And if they're deemed suitable for the virtual ward, then they're onboarded by the heart failure specialist nurses or the heart failure fellow. And they're given the electronic remote monitoring devices which record their results. And so they can then upload them to a web-based platform via the app. And then this is monitored on a daily basis, and then the patient gets a call just to check in on them. And we have monitored that. They feel that that's often enough. They don't feel that they need to be contacted more often than that. Our virtual ward is manned Monday to Friday, 9 to 5. And so we give the patients a clear escalation plan. And again, Donna will go into that in a bit more detail, should they be concerned out of those hours. And then the patients who are on the virtual ward are discussed with the heart failure consultant who's responsible for the virtual ward in an MDT. So clearly there are benefits to the patient of getting home earlier than planned, or staying out of hospital altogether, being in their own home environment. There are benefits to the heart failure team in managing the heart failure patients and getting them up titrated as we would wish, in a much more rapid way than has traditionally been done. And there are definitely hospital benefits in admission avoidance, and also getting patients home earlier and preventing those readmissions, which are common and costly. So what we achieve is rapid up titration of the heart failure medication, the 4 pillars, and that 5th pillar where the patient is able to mobilise in their own home. It's a personalised and intensive care plan, and it allows for a softer landing in the community, which the patients really appreciate. We are better integrated with the community team, and we believe that there's significant improvement in the quality of care. I'd like to just thank Nelson Amaral and Nina Carrier, heart failure consultants at the Royal Free in Barnet, who both lead on the virtual wards in our trust, our heart failure fellows, and of course our specialist heart failure nurses and our specialist pharmacists, without whom this would not be possible. And just to share some lovely news that we had this week, that we were at the NHS Parliamentary Awards as a result of our work with the heart failure virtual ward. We didn't win overall, but we were finalists for our region, so we were delighted with that. And it's great to receive recognition of the work with the virtual wards and fly the flag for heart failure awareness. Thank you for listening.
Thank you very much, Carol. That was really informative. You covered a lot of ground there in a short period of time. So just to let everyone know, I can just see that we just reached over sort of 33 people are now on. Please, if you have any questions, and I can see some questions starting starting to come in. Please don't forget to enter your questions into the Q&A section. We're now